Hello, everyone. My name is Ahmed. I'm a third-year pathology resident, and today I'm going to be talking about flow cytometry interpretation in B-lymphoblastic leukemia. So let's get started. So first of all, as you can see here, we do have our CD45 versus site scatter plot, and this plot is very useful because when we use that, we can identify certain populations in certain locations. For example, here we do have our dim CD45 population with low side scatter. This is the blast gate, and we call it the blast gate because blasts tend to fall within this gate. And for more discussion about the blast gate, see my separate blast gate video. Here, with the brighter CD45 expression in green, we have lymphocytes. Monocytes, which in this case, we have very rare monocytes, have more side scatter compared to lymphocytes. And here in blue, we do have granulocytes, and granulocytes have higher side scatter because they are more complex compared to the other cell types. We said that not only blasts fall within the blast population, there are other populations of cells that can fall within the blast gate. So whenever you have an expanded CD45 expression, the first question that you need to ask yourself is, am I dealing with a blast population? The second question is, am I dealing with a normal or an abnormal blast population? And then the third question is, if I'm dealing with an expanded abnormal blast population, what's the lineage of this blast population? Am I dealing with myeloid blasts? Am I dealing with B lymphoid blasts? Am I dealing with T lymphoid blasts? Or am I dealing with a blast population that expresses more than one lineage markers? Or am I dealing with two different blast populations with each of them expressing different markers? So all of these are questions that you need to ask yourself. So here, since I'm talking about B-lymphoblastic leukemia lymphoma, I want to start saying that when we're looking at this entity, first of all, you're looking for markers of B-cell lineage. And when we talk about markers for B-cell lineage in general, we're talking about markers like CD19, CD22, and CD79A. For CD22, you can look for surface and cytoplasmic CD22. For CD79A, you can look for surface or cytoplasmic CD79A. So these are B-cell associated markers. CD19 is expressed throughout B-cell maturation, and you cannot use CD19 to decide whether you're dealing with an immature population or a mature population, but you can use it to specify that you're dealing with a B lymphoblast population. So we said CD19, CD22, and CD79A. These are B-cell associated markers. Another B-cell associated marker is CD20. However, CD20 is only expressed in mature B cells. So if you have bright CD20 expression, then you're dealing with a mature B cells and you're not dealing with a lymphoid blast population. Another marker that is associated with maturity is surface light chains, like kappa and lambda surface light chains. These are expressed in mature B cells and they are not expressed in immature B cells. So we said first, you have to establish that you're dealing with a B cell lineage. And then secondly, you need to have an immature phenotype for these B cells. For an immature phenotype, there are markers of general immaturity in hematopoietic cells. These include dim CD45 expression and CD34 expression. So if you're dealing with a dim CD45 population that is CD34 positive, then generally speaking, you're dealing with an immature blast population. Then after that, B lymphoblast populations or lymphoblast populations in general, whether these are B lymphoblasts or T lymphoblasts, these have TDT expression. So TDT is an immature marker associated with lymphoblasts, whether these are B lymphoblasts or T lymphoblasts. However, you have to be careful because there are rare cases of B-lymphoblastic leukemia that lacks TDT expression. That's why you have to always take the general picture. Other markers of immaturity include CD10 and CD38 expression in B lymphoid blasts. CD10 is usually positive, and CD38 is usually positive, whether you're dealing with normal lymphoid blasts or whether you're dealing with an abnormal B lymphoblast population. However, you have to keep in mind that B lymphoblast population or abnormal B lymphoblast population, although they can recapitulate the normal immunophenotype of normal B lymphoid blast populations, sometimes they can have aberrancies, and these aberrancies are very helpful to help you decide whether you're dealing with an abnormal immature lymphoid blast population or a normal immature lymphoid blast population, especially when it comes to minimal residual disease testing. In this setting, some helpful markers include CD10 and CD38. We said CD10 is positive in normal lymphoid blast population, and CD38 is positive as well. Abnormal lymphoid blast populations can have bright CD10 expression, so they have overexpression of CD10. They can also show negativity for CD38. So if you're looking at a B lymphoid blast population that is bright for CD10 or negative for CD38, then you're probably dealing with an abnormal lymphoid blast population. Another point that you have to keep at the back of your mind is that B-lymphoblastic leukemia and lymphoma can express myeloid markers, and acute myeloid leukemia can express lymphoid markers as well. And that's why it's the combination of markers together rather than finding a specific marker to clench your diagnosis. Morphologically, it's extremely challenging to differentiate B lymphoid blasts from T lymphoid blasts. There are no specific morphologic features to differentiate. That's why we rely on flow cytometry to make that differentiation. Now, with all that knowledge in mind, let's look at this case here. We do have an expanded dim CD45 population. This population comprises about 91% of all the cells that are identified in this bone marrow aspirate. However, you should not be using flow cytometry to decide or to quantitate the number of blasts that you have in your sample. And this is something that we discussed in a separate video. Now here we do have our T-cell tube with our T-cell markers. And we said before that here on the y-axis you have CD34, and here on the x-axis you have CD2. So anything to the right of this vertical line is considered positive for CD2, and anything to the left of this vertical line is considered negative for CD2. As for this horizontal line here, anything above this horizontal line is considered positive for CD34, and anything below this horizontal line is considered negative for CD34. How do we draw these lines? We draw these lines using internal controls as much as possible. For example, in this case here, we do have this green population, which is our T-cell population. And then in blue, we have our granulocyte population. And we know that T-cells are positive for CD2, and we know that granulocytes are negative for CD2. So we draw this line in the middle of these two populations, the green population and the blue population. Here, our blast population in maroon is positive for CD34 and it's dim for CD45. So we're dealing with an immature population. This population is negative for CD2, for CD3, for CD5, as well as for CD7. So we don't see any expression of T-cell markers in this immature population. Here, CD56 is negative in this population. CD19 is positive in this population, and we said that CD19 is a good marker, is a sensitive and specific marker for B-cell differentiation. However, you have to be careful because acute myeloid leukemia can show CD19 expression, but CD19 expression in acute myeloid leukemia is usually dim, meaning that it's usually in the middle here, with this line being in the middle. However, this population that I see here is quite positive for CD19. So that's a very good sign that we're dealing with a B lymphoid blast population. But remember, it's the combination of markers rather than having a specific marker. So let's keep looking. So here CD7 is positive, CD19 is positive. Oh, sorry, I misspoke. CD7 is negative and CD19 is positive. Let's keep looking. Here we have our B cell tube. This population is bright for CD10. It's negative for CD20, and it's dim for CD38. So as you can see, we said that CD10 is an immature marker that is expressed in B lymphoid blasts. And then if you're dealing with a bright CD10, then you're probably dealing with an abnormal B lymphoid blast population. And I call it bright because it's all the way here to the right of this vertical line. If it was here in this population, that's more of what I expect for a normal B lymphoid blast population. But let's keep looking. CD19 is positive. CD20 is negative, and we said that CD20 is expressed in mature B cells. It's not expressed in early B cells, and these early B cells, they gain CD20 expression as they mature. So that's a sign that we're dealing with an immature B lymphoid population. And then we do have CD38 here. So I'd call this CD38 dim. And CD38 is usually associated with B lymphoid blasts. It's a marker of immaturity in this setting. However, remember, if you're looking at a completely negative CD38, then you're probably dealing with an abnormal B lymphoid blast population in this setting. Here we do have our kappa and lambda light chains. And as you can see here, our population is negative for both kappa and lambda light chains. So that further consolidates the fact that we're dealing with an immature B lymphoid blast population. Let's keep looking. Here we do have our myeloid blast population. Excuse me. Here we do have our myeloid tube. In this myeloid tube, as you can see, CD33 is negative, CD13 is negative, and CD117 is negative. CD117 is an immature marker that is seen in myeloid blasts. So it makes sense that this marker is negative here. CD13 and CD33 are myeloid-associated antigens. However, just remember that CD13 and CD33 and other myeloid markers can be expressed in B-lymphoblastic leukemia. Here, CD123 is positive in about 97% of these cells, and that's helpful because we do have targeted therapy against CD123. HLA-DR here is bright, and HLA-DR can be positive in both acute myeloid leukemia and B-lymphoblastic leukemia. So it's not really a useful marker when it comes to differentiating the lineage between myeloid lineage and lymphoid lineage. More of the same, CD13, CD33, and CD117 are negative. CD123 is positive, HLA-DR is positive. And here we do have our monocytic tube. CD11b is negative, CD16 is negative, CD14 is negative, and CD4 is negative. CD64 is negative as well. So we don't have any expression of monocytic antigens. And lastly, here, MPO is negative. MPO is the most specific myeloid lineage marker. And if you have MPO positivity, then you have to consider mixed phenotype acute leukemia in this setting. However, you have just a dim MPO and you don't have any expression of any of the other myeloid markers, then you have to back off from calling mixed phenotype acute leukemia. And I'm going to discuss mixed phenotype acute leukemia in a separate video. But for now, remember, MPO should be negative in B-lymphoblastic leukemia. TDT is positive, and we said that TDT is an immature lymphoid marker, so that supports our findings so far. CD79A is a marker of B-cell differentiation, and it's positive in this case as well. So we're definitely dealing with a B lymphoid population or a B lymphoblastic population, and cytoplasmic CD3, which is the most specific T lymphoid marker, is negative in this case. Whenever we're dealing with an acute leukemia, and we're probably dealing with a B lymphoblastic leukemia lymphoma, we do have our B lymphoblastic leukemia lymphoma add-on, and let's have a look at this. And as you can see, this is our blast population in red. It's positive for CD34, positive for CD10, positive for CD19, positive for cytoplasmic CD22, positive for TDT, negative for MPO, and negative for cytoplasmic CD3. So the overall findings that we have here is we're dealing with a B lymphoid blast population that is positive for B cell markers, including CD10, CD19, cytoplasmic CD22, and this population is dim for CD45, it's positive for CD34, which are general hematopoietic markers. TD2 is positive in this population, supporting lymphoid lineage. Cytoplasmic and surface CD3 are negative, excluding a T lymphoblastic population. And we said MPO is negative, excluding a myeloid blast population. Here, CD38 is dim. CD20, which is a marker that is expressed on differentiated mature B cells, is negative in this case as well. So looking at all these findings together, we're dealing with a B lymphoblastic population supporting a diagnosis of B lymphoblastic leukemia lymphoma. And you have to look at this flow cytometry in conjunction with morphology on the peripheral blood smear, bone marrow aspirate, as well as bone marrow core biopsy. Let's have a look at another case. We do have this case here of a 45-year-old patient who presented with shortness of breath. CBC was done, and peripheral blood smear showed increased blasts. And flow cytometry was done on a bone marrow core biopsy. Remember, you can do a flow cytometry on peripheral blood, you can do that on a bone marrow aspirate, or you can do that on bone marrow core biopsies, like the actual biopsy fragments. The only problem with that is usually we tend to not have a lot of cells, and that's why we tend to do limited panels when we're dealing with a bone marrow core biopsy. So here we do have an expanded dim CD45 population. This population is negative for CD117, which is an immature myeloid marker. However, CD13 and CD33 are positive in this population. CD19 is also positive in this population, and CD7 is negative. So as you can see, we do have expression of myeloid markers like CD13 and CD33, and we do have an expression of the B-cell associated antigen CD19. So let's keep looking. Here, this population is positive for CD10, it's positive for CD19, it's negative for CD14, which is a monocytic associated antigen. And then let's look at the B-lymphoblastic leukemia lymphoma add-on. This population is negative for MPO, and this population is dim for TDT and positive for CD79A. And as you can see here, HLA-DR is positive, and cytoplasmic CD3 is negative. Interestingly, this population is negative for CD34. So, in summary, we're dealing with a DIM CD45 population that is CD34 negative, CD117 is negative, but MPO is negative, cytoplasmic CD3 is negative, and we see expression of B cell markers, including CD19, CD10, CD79A, and TDT. So putting all these findings together, we're dealing with a B-lymphoblastic leukemia lymphoma. The message that I'm trying to convey in this case is that sometimes you can see expression of some myeloid markers like CD13, CD33. Some cases can show expression of other markers like CD15 and CD65. However, you should not see myeloperoxidase expression. Now, the last thing that I want to discuss is that flow cytometric findings can be associated with specific subtypes of B-lymphoblastic leukemia lymphoma. As you can see here, we do have so many subtypes. I'm going to go quickly through these. As for the general entity B-lymphoblastic leukemia lymphoma, the lymphoblasts always express B lineage associated antigens like CD19, cytoplasmic CD79A, cytoplasmic and surface CD22. These are best demonstrated by flow cytometry. When it comes to tissue sections, PAX5 is actually the most sensitive and specific B lineage antigens. Cytoplasmic CD79A can also be used in tissue sections. The patterns of antigen expression associated with B cell immaturity are commonly present and imperfectly recapitulate stages of early B cell maturation. As we said, you can have a dim CD45 expression. You can have CD10 expression, often moderate to high intensity. And we said that if you have bright CD10 expression, then you're probably dealing with an abnormal B-lymphoid blast population. Variably low to absent CD20. CD20 is usually negative in B-lymphoblastic leukemia lymphoma. CD34 is usually positive. However, there are some cases that are CD34 negative, like the case that we just looked at. And TDT is positive in the majority of cases. However, there are some rare cases of B-lymphoblastic leukemia lymphoma that are TDT negative. That's why it's always the combination of markers. As for the entities B-lymphoblastic leukemia lymphoma with hyperdiploidy or with hypodiploidy, or with intrachromosomal amplification of chromosome 21, these usually tend to have a general immunophenotype for B-lymphoblastic leukemia lymphoma. However, some cases, like B-lymphoblastic leukemia lymphoma with BCR-ABL1 fusion or the Philadelphia chromosome, usually in these cases, in addition to the B lineage markers, blasts frequently express the myeloid-associated antigens CD13 and CD33, and CD25 is also frequently expressed in this entity. As for B-lymphoblastic leukemia lymphoma with BCR-ABL1-like features, we do have CRLF2 overexpression by flow cytometry, and this is a surrogate marker for CRLF2 rearrangement that can be seen in B-lymphoblastic leukemia with BCR-ABL1-like features. As for B-lymphoblastic leukemia lymphoma with KMT2A rearrangement, the blasts typically have a CD19 positive, CD10 negative, CD24 negative immunophenotype, and they are often positive for myeloid markers like CD15 and CD65. TDT negativity, which is uncommon in B-lymphoblastic leukemia and lymphoma overall, is also relatively frequently seen in B-lymphoblastic leukemia and lymphoma with KMT2A rearrangement. As for B-ALL with ETV6 RUNX1 fusion, the blasts are usually negative or partially positive for CD9, CD20, and CD66. This phenotype appears to be relatively specific for this subtype. Myeloid-associated antigens, especially CD13 and CD33, are frequently expressed. Then there's a CD27 positive, CD44 low to negative immunophenotype. This is seen in B-lymphoblastic leukemia lymphoma with ETB6 RUNX1 fusion, as well as ETB6 RUNX1-like features. As for B-lymphoblastic leukemia lymphoma with TCF3 PBX1 fusion, the abnormal B lymphoid blasts show strong CD9 expression, dim to negative CD34 expression, and at least partial absence of CD20 in addition to CD19 and CD10 expression. Interestingly, cytoplasmic mu heavy chain expression is frequently present, but this finding is not actually specific for this entity. As for B-lymphoblastic leukemia lymphoma with TCF3 HLF fusion, CD19 expression is typically high, but as you can see, this feature is not specific and it can be seen in other entities in this table. As for B-ALL with IGH-IL3 fusion, the lymphoblasts show the typical expression of CD19 and CD10. However, a subset of cases can show expression of myeloid markers like CD33 and CD13, and both lymphoid blasts and eosinophils express the IL-3 receptor CD123. As for B-lymphoblastic leukemia lymphoma with other defined genetic alterations, it depends on the specific alteration. For example, DUX4 rearrangement can show positivity for CD2, which is a T-cell associated antigen. It can also show expression of CD13, which is a myeloid associated antigen. As for MEF2D rearrangement, these can be CD10 negative and cytoplasmic mu heavy chain positive. As for ZNF384 rearrangement, these can be CD10 negative and positive for some myeloid markers like CD13 and CD33. And as for the PAX5 alteration here, these can be positive for CD2 as well as CD33. So the general message that I'm trying to convey here is that we have a general immunophenotype. In this general immunophenotype, you want to see markers associated with B-cell differentiation, like CD19, CD22, and CD79A. And if you're dealing with tissue sections, then PAX5 as well. You want to see markers associated with immaturity in general, like dim CD45 expression and positive CD34 expression. You want to see markers associated with immature lymphoid differentiation, like TDT. And you want to see markers that are commonly seen in immature lymphoid blasts, like CD10 and CD38. And you have to lack expression of markers that are associated with maturity, like CD20, as well as the light chains, kappa and lambda. And here I'm talking about surface light chains. Myeloid markers can be expressed in B-lymphoid leukemia, B-lymphoblastic leukemia lymphoma, like CD13 and CD33. However, remember that MPO should not be positive. If MPO is positive, then you have to consider mixed phenotype acute leukemia, especially in this setting. But that's a discussion for a separate video. And then lastly, remember, it's about the general picture, especially when it comes to B-lymphoblastic leukemia lymphoma. It's not finding a specific marker and then making the diagnosis. It's more about looking at the general picture and then after that, coming up with a diagnosis. This is the end of this video. I'll see you next time.